Assalamu alaikum. I'm Dr. Sharmin Ahmed, Junior Consultant from Department of Cardiology. Welcoming you all to today's CME program. INCLISIRAN is a small interfering RNA therapy that lowers LDL cholesterol by inhibiting PCSK9 protein. So, today's presentation is on INCLISIRAN, a novel lipid-lowering agent. We are honored to have Professor KMHS Sirajul Haq sir, former Chairman, Cardiology and former Dean Faculty of Medicine, BMU, and former President, Bangladesh Cardiac Society, as today's special guest. We are also privileged to have renowned cardiologist, Professor Dr. Sajal Banerjee sir, former Chairman, Cardiology and former Dean, Faculty of BMU, as our special guest. We also have among us Dr. Ahmed Jahid Hussain sir, Managing Director of BSH, as special guest. Today's CME program will be chaired by Professor Brigadier General Mamun Mostafi sir, Chairman, Academic Research and Publication Committee, BSH, and also chaired by Professor Abdullah Shafi Mojumdar sir, Director, Medical Service and Consultant, Department of Cardiology, BSH. Today's keynote speaker will be Professor Dr. Mahmudullah Firoz sir, Consultant, Department of Cardiology, BSH. As panel of experts, we have Professor Dr. Muhammad Amirul Haq sir, Professor Dr. Muhammad Khalid Mohsin sir, Professor Dr. Muhammad Mir Jamaluddin sir, Professor Dr. Abdul Wadud Chaudhary sir, Professor Dr. Muhammad Abdul Wahab Khan sir, Professor Dr. Abdul Momen sir, Professor Dr. Mahmudul Haq sir, Professor Dr. Naran Chandra Kundu sir, Professor Dr. Muhammad Sohailul Islam sir, Dr. Muhammad Sulaiman Tanvi sir. And scientific program for today's CME, scientific partner will be Navian Life Science. So, I request Honorable Chief Guest, Special Guest, Chairpersons and panel of experts to take their seat kindly. Now, please welcome today's keynote speaker, Professor Dr. Mahmudullah Firoz sir, to give his presentation. Thank you.
About this lipid one. We all know that non-communicable disease is the main killer of human being at this moment, and around 20 billion people every year die of cardiovascular. And if you think of the other non-communicable diseases like cancer, respiratory disease, diabetes, malaria, CKD, and many others, and this number of cardiovascular disease will be increased by 2030 around 24 billion every year. So this means in each minute, every 60 seconds, 34 people die of cardiovascular disease. What about the Bangladesh condition? In Bangladesh condition, according to DC Health, around 30% of death, or 1/3 of the death of our country happens because of the cardiovascular disease. And at the moment, around 1 crore people are suffering from cardiovascular disease. Around 10 lakh people, 10 lakh new cases of cardiovascular disease every year, more than 2,000 cases every day. And in Bangladesh, around 2 lakh STEMI cases are there in Bangladesh. That means every day, 550 patients suffer from acute elevation anemia. And as there is many of the services are in the capital cities or in the divisional cities, and many of these diseases happen also in the rural areas, the mortality rate is very high in our country in comparison to other countries because of the lack of facilities of the acute management. And the consequence of these acute conditions leads to the out-of-pocket payment from our patients, which has got a devastating effect on the poverty and rural income. And these cardiovascular events happens at least 10 years earlier than the Western population. So many of our relatively young people who are in their 5th or 6th decade suffer from these acute events, and this leads to an impact on their social life, their economic condition, financial condition, family condition, and everything. So we should think about this prevention of cardiovascular disease more and more. And this is a scenario of severe cardiovascular risk factors in our country, and there are some encouraging results in the salt intake and smoking, but the rest of the conditions are increasing day by day. Not only that, the age pyramid also is being changed. This is the age pyramid of 1971. This one is around 2005, around 2020, and hopefully this will be in 2050. So more and more senior citizens will be there in our country. So the cardiovascular diseases, the incidence and prevalence of cardiovascular disease will be increasing. So what we can do, we can delay this process of acute cardiovascular events by controlling these risk factors. So one of the important things, the good thing, or you can take guide of, that this atherosclerosis happens only in the human being. Why that happens? In the during evolution, there is a gene called CME gene, which was deleted in the human trace. That led to the atherosclerotic process of the human being. And no other animal develops atherosclerosis. Like the carnivorous people, guinea pig, nowhere you can get this atherosclerosis. And the reason behind is the vascular reaction to the lipid. The lipid is always there in the blood in all animals. It enters the subendothelial layer, and in case of human being, there is an inflammatory reaction and other reactions, which I am going to show later. This is unique in case of human being. That leads to the atherosclerosis and the cardiovascular disease condition in case of human being. And these three main factors which is responsible for this atherosclerotic disease are, one of them is the LDL level, high systolic blood pressure, dietary habit, and definitely other things like smoking, physical inactivity, and many other things are there. So there are so many trials, dozens of trials, we have shown that LDL has got a direct relation with the causation of these atherosclerotic cardiovascular diseases. And if you can reduce the LDL level by 1 millimole per liter, you can reduce the rate of heart attack, you can reduce the atherosclerotic cardiovascular events. And two things are important: the level of LDL and how long the person is exposed to this high level of LDL. Both have got a synergistic effect on the incidence of cardiovascular disease. So we all know as a medical graduate about this chart. I am not going in details of this one. So we try to control these lipids, the LDL. What are the mechanisms? One of the mechanisms is the interfering the synthetic process of the LDL cholesterol, and we use statins, we use ezetimibe, bempedoic acid, and many other bile acid sequestrants. All these things will reduce the synthesis of cholesterol, specifically LDL, in case of hepatocytes. But there are many other ways. One of the important thing is the LDL receptor in the hepatocytes. And this LDL receptor concept and the control of taking this LDL receptor concept started in 2003. These are the LDL receptors in the surface of the hepatocyte. The job of this LDL receptor is to collect the LDL from the circulation and it internalize it within the hepatocytes. There is another village there, that is the PCSK9. This PCSK9 is an enzyme which binds with this LDL receptor and tries to internalize it within the cell. The more LDL receptor is on the surface, more LDL will be removed from the circulation within the hepatocyte, and there will be the atherosclerotic process. So we have to try with this PCSK9. And for this, there is an antibody was developed, which is known as PCSK9 inhibitor. This PCSK9 inhibitor inhibits this PCSK9. So it makes more and more LDL receptor on the surface of the hepatocyte, which is helpful for our patients. And these are the alirocumab, eculocumab, and many other receptors. So who are the candidates of this lipid molecule? Definitely the patients who has got clinical atherosclerotic cardiovascular disease, that means history of acute coronary syndrome, myocardial infarction, stable angina, coronary or other arterial revascularization, stroke, EIA, peripheral artery disease. That means the clinical atherosclerotic cardiovascular disease, and also the subclinical atherosclerotic cardiovascular. Both these people are candidates of lipid lowering therapy, and it is a secondary prevention. And in case of primary prevention, and there is some disturbance in the because of the change of the laptop, it has become blurred. But I can tell you, in case of diabetic patients, the latest guideline by the American College of Cardiology says in between 40 to 75 years, all the diabetic patients should get lipid lowering therapy. And beyond that, that means beyond 75 years, you have to talk with the patients. It will be patient-doctor sharing of the decision whether it will be lipid lowering therapy or not. And if it is less than 40 years, that means 20 to 40 years of age, you have to go for the risk scoring of the patients. If the risk scoring is high, then you should give the lowering therapy. If it is low, you don't need to give the lipid lowering therapy. What is the risk scoring? I'm going to tell you about the risk scoring later on. And this is also in case of patients who need primary prevention in case of atherosclerotic cardiovascular disease without atherosclerotic cardiovascular. These are the patients who need risk scoring. If a patient has got a risk of developing an acute atherosclerotic event in the next 10 years, I mean, if it is more than 5% chance, he should get a lipid lowering therapy. If the chance is between 3 to 5%, you may give lipid lowering. If it is less than 3%, you don't need to give the lipid lowering. So risk scoring is important. আমি যেটা বলছিলাম যে ল্যাপটপ চেঞ্জ হলে সাধারণত এটা চেঞ্জ হয়ে যায়। So what should be our goal? The goal of lipid LDL cholesterol control depends on the severity of the atherosclerosis. The more severe the atherosclerotic cardiovascular disease, the lower should be the LDL level. Like in a very high risk atherosclerotic cardiovascular disease conditions, who has got 2 or more events of atherosclerotic cardiovascular event, or recurrent atherosclerotic cardiovascular event despite having lipid lowering therapy, the level should be, LDL level should be 40 or less. In case of clinically evident atherosclerotic disease, that has been very high risk patients, it should be less than 55. In moderate risk patients, it will be less than 70. In other patients, it should be less than 50. So, what is the normal cutoff value for LDL? Depends on the patient. If the patient has got a severe cardiovascular disease, atherosclerotic cardiovascular disease, the lower will be level. There is no such value which will tell you that is universal for every patient. So, the common drug we use is the statin because it is the backbone of the lipid lowering therapy. There are dozens of trials we have shown that this statin is effective and it is a class 1 drug for any atherosclerotic cardiovascular disease treatment as well as prevention for primary and secondary prevention. But statin has got some drawbacks. Statin has got side effects. Like 10% of the patients develops statin-related muscle symptoms and many other symptoms of these statins like liver enzyme induction and many others. Target level may not be always achieved by the maximally tolerated dose of statin. And there is a residual risk of developing atherosclerotic cardiovascular disease because even after control of the LDL, many of our patients has got normal LDL level or low LDL level. Despite that, they have got atherosclerotic cardiovascular disease or acute events. The reason behind is the residual risk of atherosclerotic cardiovascular. That means beyond LDL, there are many other molecules which may cause atherosclerotic cardiovascular. And daily dose of statin is also important. It reduces the adherence of the patients. And if you think about the efficacy of the patient, what a statin can take control of reduce the level of LDL by 30 to 50%, depending on the LDL statin which are you using and the dose of the statin. The reduction will be 30 to 50%. If you add other drugs like ezetimibe or PCSK9 inhibitor or INCLISIRAN, you can reduce the LDL level up to 85%. This is important. Another important thing is how much of our patients are able to achieve their target LDL level in patients. This is a study in the Indian ACS patients, and 80% of their patients are not able to reach the LDL cholesterol level using only statin. So you need something more than statin. And another important thing is the adherence. 50% of the patient will discontinue statin within 1 year of time. So what's new? We need something which is powerful, which is effective, which is safe, and which will give you more adherence to the drug. And RNA therapies are important. So these are the two gentlemen who are awarded Nobel in the field of physiology or medicine, Andrew Fire and Craig Mello. They invented the technology of RNA interference. And in the COVID era, we have gone through the different vaccines which was produced with using this technology. What is this? The INCLISIRAN is one of the important RNA drugs which is being used in the using the messenger RNA or RNA technology. There are many other drugs in the pipeline. Mostly the metabolic diseases are being tried to control it by using this RNA technology. What is the mechanism? In case of INCLISIRAN, you have got two RNA strands with some designs which will help the INCLISIRAN to internalize within the cells. One of the strands is called guide strand, another one is passenger strand. Passenger strand is the guide strand which will do the work, and the guide strand will help it to go inside the cell. So the mechanism is a bit clumsy. The initial one, the INCLISIRAN is internalized within the cell. The design is separated from the INCLISIRAN, and this INCLISIRAN is again binds with the IRS3 complex. The passenger strand and guide strands are separated, and the passenger RNA binds with the messenger RNA of the cell itself. There are some messenger RNA which will be responsible for the synthesis of PCSK9 enzyme, which destroys the LDL receptor. The job of this INCLISIRAN passenger RNA is to bind with that messenger RNA, and this will deactivate the messenger RNA, which is responsible for the synthesis of PCSK9, and this will reduce the value of the PCSK9. This will make more LDL receptor on the surface of the hepatocyte. This will help to clear more and more LDL from the circulation, and it is being approved by the FDA in different conditions like atherosclerotic cardiovascular disease or atherosclerotic cardiovascular disease equivalent and heterozygous familial hypercholesterolemia. And the dose schedule is very simple. You have to give the single dose, then after 3 months the second dose, then every 6 months. That means twice in the 2 injections every year. So there are number of trials which are conducted using this INCLISIRAN, and in the phase 1, phase 2 and phase 3, and all these drugs has shown that there is at least 50% reduction of the LDL cholesterol if we use in different subsets like ASCVD, ASCV equivalent or heterozygous familial hypercholesterolemia. And if you can add other drugs, then it can, like statin, it can get control of the LDL level up to 80%. 80% control. Is it safe? They have conducted the study and said that there is no genotoxic or carcinogenic effect, no effect on fertility or embryonic development, and no dose adjustment is necessary for renal or hepatic impairment patients. So, is it effective in case of Asian populations? Yes. Maybe Asian population also, it reduces the LDL level by 50%. What is the current guideline of lipid lowering therapy? Definitely, statin is the number one. Statin, the highest tolerable dose, should be given in each and every cases. The second line drug, in many of the trials, it is ezetimibe. The third line drug is bempedoic acid, PCSK9 inhibitor, or INCLISIRAN. We have to keep in mind that INCLISIRAN is not a first line drug in all patients, except in patients who are statin intolerant, who are developed statin myotoxicity or many other things. On that case, you can give it INCLISIRAN as the first line drug. Otherwise, it is a second line drug. It can reduce the. Is it cost effective? Because it is a costly one. In our country, the company people will tell you the cost of this INCLISIRAN, each dose is around 1,40,000 Bangladeshi taka. So, is it cost effective? This is an India study. they have shown that this is cost. It has got cost benefit ratio because it will reduce the atherosclerotic cardiovascular disease. It will reduce the acute atherosclerotic cardiovascular disease events. So it will be cost benefit. It has got a cost benefit. One of the important concern is the reduced LDL level. Is it safe? There are many myths regarding the low LDL level that it can produce like neurocognitive disorders, hemorrhagic stroke, worsening blood glucose, and onset of diabetes mellitus, many other things. But the trials which was conducted with PCSK9 inhibitors, like the 4-year trial or Odyssey trial, Odyssey outcomes trial, they have shown that the LDL level as low as 30 milligram is safe. So there is no lower level of the LDL level by which you should reduce the dose or something. And if you think about the adherence, in case of statin, you need 365 pills a year. In case of PCSK9 inhibitor, you need 26 injections a year. And in case of INCLISIRAN, you need only 2 injections per year. So it will definitely improve the adherence of the patients. So ladies and gentlemen, there is a log linear relationship between the LDL level and ASCVD. Lower is better. There is no proven safety threshold beyond which you should reduce the LDL level. Lifelong low LDL is associated with low ASCVD risk, and after acute coronary syndrome or any acute atherosclerotic event, you have to strike early. That means very early initiation of the lipid lowering therapy, and you should strike hard. Give your best shot. Give the highest level of the statin and other supplementary drugs. INCLISIRAN is a new weapon to achieve better control and adherence, definitely. And one important thing we should keep always in mind, do not de-escalate therapy solely on due to very low LDL, especially in high-risk patients. Thank you. Thank you for your patience.